me introduce our very special guest. Valerie is a licensed practical nurse and a senior care expert with over 30 years of experience. Much of her career has been spent in skilled nursing facilities as director of residential care. She's worked at 2 assisted living centers, was the home care manager of an independent living community, and most recently, Valerie provides hospice and palliative care services at Lower Cape Fear Life Care Center in Wilmington. Please join me in welcoming Valerie Moreau.
Thank you. Connie, thank you very much. And hello, everyone. Thank you for coming today. It's encouraging to see you all here. I have been a nurse for 30 years, and I've seen a lot of things over the span of my career in long-term care, in acute care, in hospice care, in surgical centers. And I gleaned from those experiences what I bring to you today, and I hope that you'll find it helpful. I want to send out a special thank you to Ellen DeGroof and the rest of the Nest folks who invited me here. I have had the pleasure of serving, I think it's 6 families that reside in St. James over the last 3 years, and it's been an honor and a privilege. So I think that's how Ellen and I met each other. I kind of refer to it as firefighting. We'll talk a little bit about that in a minute, and how to avoid firefighting and perhaps doing fire prevention. So this is just the beginning slide. We're going to move on, I hope. Oops, maybe we're not. Oh, it doesn't like that answer. This way? Oh, look at there. And I'll special thank you to Jerry and to my son who did this PowerPoint presentation. So you've heard a little bit about my clinical background. Many of the years that I've spent, even though I've done a lot of things, have been serving seniors. It's a heartfelt mission for me. I lost both my parents when they were young. When I was young, I was 25 years young. Lost both my parents 6 days apart. And so you all fill a very special place in my heart. And serving and being a part of your families is really how this turns out. I get invited in. Woohoo! My professional mission here and what has developed over the last several years is to help seniors to be informed about what your choices are and about managing your expectations, whether it's hiring for home care, whether it's, unskilled services, you're wanting somebody to drive you to the grocery store, or you need somebody to come in and do some meal prep, or this is very personal care. You need to know what that looks like and what can I expect when I hire folks to do those things. So what I found when I was a director at an assisted living, when I was the manager of home care in a very lovely independent living, is that people don't know. It's not, why would you? It's not your area. But if you are only learning from someone who's selling you a product, then perhaps you're getting a biased view, would be my guess. And so I want to promote just general knowledge and empowerment. So this is not a doom and gloom. We left them at home, kicked them to the curb. We don't want them around here. This is an empowerment series. And I feel honored to be leading off this series for Ellen and for the rest of Ness and for all of you. And I look forward to your questions. We will get there. Oopsie. There we go. There. So what for me began as I started putting this together was beginning the conversation. And it's a hard conversation for all of us. And it's a conversation about aging and about mortality and about illness and about limitations. Because for most of us, that's the reality. There are a small number of people who live well into their 90s and even their hundreds who maintain most of their abilities right up until the very end. They are in the minority. Most of us begin to experience decline typically in our 50s, where we begin to notice, I that didn't used to hurt. Oh, gee, I can't walk as far as I used to. And then we begin to notice more and more of those things, and we're not as strong, we don't have as much going on. So the sooner that we can begin that conversation, and how do we want to support our needs? Because as we go through this, you'll see there's lots of ways to do that. But if we wait until the house is on fire, and I use that a lot, then what we get is an abbreviated version of those services, because we have to prioritize them. We have to find out what's the most immediate need and how can I help in the moment. And unfortunately, by that time, it's a lengthy list, in my experience. So that's why, in my mind, it's such an important conversation, first to have with yourself, then to have with your family, your partner, your spouse, your family, your kids. It needs to be a conversation. What do you want your later years? We're in the winter of our lives. What do we want that to look like? So the first piece of that is identifying needs. And nobody knows better than you. You might not want to talk about it, and we'll talk about that in a minute. But you know what your needs are. So identifying them, and then what are the interventions? And the earlier you intervene, you're going to maximize your independence. If we wait until we are so overwhelmed or so disabled by whatever is going on in our lives, getting to maximize or to the maximum independence is probably not going to happen. Because when we begin to lose ground, gaining it back at our age is a little bit tougher. An ounce of prevention is worth a pound of cure. We all know that, right? And that is so true when we're talking about wellness. It really and truly is. So even though you're like, I don't want to go, I don't want to have this conversation with the doctor, I don't want to talk about fill in the blank, whatever it is, if I can encourage you to start having the conversation with your provider, you may find that there are pretty simple interventions that are going to make a whole lot of difference about the outcome. So we create unnecessary barriers when we hide or minimize the decline. It does you no service, except to work you closer to the house being on fire, and then needing multiple people to come in and help to put the fire out and to get things back under order. So if you can resist the urge to, either for yourself or for your loved one, to mask those things and to try to tuck them under, and I'll take care of it, it's okay, I'll take care of it. And you may still have to take care of it. But we need to talk about it first, and we need to bring it out into the light, because sometimes there are simple interventions that will make all the difference in the world. And I talk about why do we do it. Fear the unknown. It's the biggest fear of all. We're all afraid to some degree of what we don't know. And what is our life going to look like down the road? And as we begin to experience these declines, then looking out on the landscape is scarier and scarier. Shame or embarrassment. Who wants to talk about incontinence? It's not fun. You know what I mean? It's not something we bring up at the tea party or the, golf club. You know what I mean? And nor should you. But it needs to be talked about. And oftentimes there will be interventions that will help to manage those symptoms quite well. Anger. How many of us are mad that we can't do the things we used to do? Anybody? Yeah. You know what I mean? I used to run. I was a gymnast at one time. Yeah, none of that's happening. How many of you in the last 6 months have known a good friend or a relative who has had a devastating diagnosis? So if we can all leave our hands up for just a minute and then turn and look through the room. This is powerful, and it happens. all the time. And those people, I would venture to say that 50% of those had some signs early on that they didn't want to look at, that they didn't want to share with their family, that they didn't want to go to the doctor about. And then when they did, sometimes it's gone beyond where we can get maximum independence. How many of you in the room feel 100% prepared should you get that diagnosis? If everybody take a look around the room. Not one hand up. And that's why this series was born. This was, Ellen and I started talking about this quite some time ago. Because we assisted folks who the house was truly on fire, several actually. I'll spend about 5 minutes giving you a little bit of background about what that may look like. And I'm not going to name names, obviously, but it can be quite significant, and the outcome was not great. So we anticipate the loss of independence, right? As we begin to feel these things coming up and creeping up, and how my knee hurts, and oh my gosh, my shoulder, boy, you can't put the dishes away anymore. All of those things are like, oh, this isn't going to look too good another 6 months down the road. And then grappling with our mortality. I think that's a human condition. And that doesn't mean that we all don't have, or some of us don't have wonderful spiritual conviction and belief, and that's a wonderful thing. I think most of us still, to one degree or another, grapple with our own mortality. And all those things up there are why we create the unnecessary barrier, why we deny, why we don't reach out, we don't start the conversation. Early intervention almost always has improved outcomes. Denial equals unnecessary stress and accelerated decline. And I want to spend a moment on the accelerated decline. One of the couples that I served in this community did just that for quite a while, denied. And the wife had a chronic degenerative disease that had been getting progressively worse, and her husband was the primary caregiver. And he was doing an amazing job, but he wasn't talking to the providers, his family, her family, about the decline until such time as she had 2 significant falls, both of them with head injuries. By the time he called me, she had gone from ambulating with a walker and being conversational to being profoundly confused and bedbound and requiring 100% care for all of her activities of daily living. She shortly then went on hospice. And meanwhile, because he had been the primary caregiver and had taken care of her, he had had a 57-pound weight loss. He weighed 113 pounds when he called for my help. And he couldn't tolerate any food because his anxiety was off the grid. So, when we talk about accelerated decline, that's exactly what it looks like. When we avert our gaze and we don't want to have the conversation and we wait until it becomes so significant that we now need somebody to please come in and fix this, not only does it affect the person who's grappling with the illness, but their loved one and primary caregiver to a significant degree. He could have lost his life. When I first came on board, I remember having a conversation with Ellen. I was more concerned about him than I was about her, because she was getting her needs met, and we were able to identify, we were able to bring, palliative care was in initially, and then hospice care, and we could meet her needs. His needs were much harder to address. So please don't think that you're doing yourself or your loved one any service by keeping it all in and doing it all yourself. It takes a village. It truly does. And so Nest, Ellen, Valerie, myself, were able to wrap ourselves around that family. Her desire was to go back home to Massachusetts. I flew out to Massachusetts twice, found facilities for her. I went out when she was actively dying and stayed with her husband. And so it was the best possible outcome that it could be at that point. And I'm happy to tell you he weighs 142 pounds today. Woo! And he feels 110% better. But he could have had that. They both could have had that. And they may have had more time together if we could have supported her earlier on and not come in when the house was on fire. Okay? So there's some pretty basic interventions that go a long way. Inform and involve your provider. It's so important. Even if you feel like, this has been going on for a long time, this isn't anything new. If it's outside of the normal aging process, and they will be able to, in the next slide you'll see, your provider will be able to help you identify, maybe that is part of the normal aging process. Many, many times it's not. And there are things that can be done, whether they're medications, whether they're treatments, whether they're change in lifestyle. There are things that can be done to mitigate the progression of those things, and sometimes to eradicate them altogether. Define and embrace your support system. That is such an important part of us all aging. I've recently had conversations with my own children. Each other. You need to talk with each other. What is it that we want, and how can we get there? Who do we have out in the world who can offer some support for us? And then choose care services, and choose them wisely and in an educated way, because it makes all the difference. There's nothing worse than having to go through 3, 4, 5 organizations before you find one that meets your needs. There are questions, pivotal questions to ask, ways to do your homework, so to speak, and see kind of what their reviews look like. So those, for me, are the first 3 most important steps coming on the heels of the initial conversation. When you inform and involve your provider, be a good historian. Again, try not to hide and keep things secret, you know what I mean, or minimize them. The doctor, the nurse practitioner, the PA, whoever it is that can't help you if they don't comprehensively understand the degree of your symptoms or your problem. So if you are experiencing things that feel a little bit chronic, start taking notes. Make your appointment, and then between the time that you make your appointment and you actually go to see your provider, keep kind of a little bit of a log specific to those symptoms or those concerns. That's invaluable to the provider. Acute versus chronic. I can't tell you how many people I have seen over the age of 60 who all of a sudden are profoundly confused. They are unable to ambulate the way that they were previously. Their appetite is not good. They're not able to go to the bathroom, and you know what? They got a UTI. They've got a urinary tract infection. And so they don't present in the same way when we get a little bit older as they do when we're younger. But the provider, that'll be one of the first tests they'll run. When you come in and they hear a specific group of symptoms, typically they check your blood and they do your urine. Anyway, regardless, that's one that is so prevalent, but it's profound, and the changes can be profound and frightening. Medication management. So for some of those other things that are a little bit more chronic, perhaps we just need to talk about medications. Perhaps there needs to be a new medication that will help to manage the symptoms. And here comes a biggie. Advanced directive discussion. Now there's further on, we're going to talk a little bit more about that. I cannot tell you how important it is to get your advanced directives in place. So that can be a living will. It can be a most form. It can be a DNR. Those do require provider signatures. It can be a living will. There's many, but when we get a little further along, I'm going to show you the most important 4 in my experience. And DNR and your most form is your assurance that your wishes will be honored. If it's up here and only you know it, or even if you've shared it with your loved one, but there's nothing to back that up, they can't honor it. So the provider is going to then make the decision for you, and they might ask you. But if you're in a situation where you're unconscious and they can ask you, and you don't have a DNR, they're on your chest. And they're going to be doing cardiopulmonary resuscitation, whether you want it or you don't. So please know that. These are really, really important things. And that is absolutely a discussion to have with your provider. Because the ones, the most form and the DNR are going to require a physician's signature. And the most form has to be updated annually and signed. So, define and embrace your support system. The first thing I want to talk a little bit about is managing your expectations. I had another client in St. James who the spouse, the wife, had pretty profound dementia, and her husband was pretty ill, congestive heart failure, pretty compromised. And they had wonderful, wonderful neighbors that helped out and would check on them and help them get to appointments. And it was a wonderful thing until it wasn't. By the time I got the call, he lived less than 2 weeks. And she was beside herself and lived alone, essentially. Had support, but lived alone. For someone who has profound dementia, it is an unsafe situation for them to be left alone. It's a hardship, and it's a hard thing to hear, but it is the absolute truth. I have been on the other side of way too many instances where terrible things happened and people felt horrible because she's always been okay before, or she's never wandered outside of the house before. Dementia, just by the nature of what it is unpredictable. And we can't guarantee someone's safety if they're alone. And when they're alone, often it causes anxiety, and that anxiety causes them to want to wander and find out what's going on, and they're not really sure what they're trying to find out, but they know that it doesn't feel right. So, yes, we absolutely want to support each other as neighbors. I would just say, be mindful of boundaries. And boundaries that not only protect the person offering the service, but boundaries that truly protect the people you're helping. Because everybody had a wonderful heart and everybody was doing the very best that they could. But what that couple needed was far beyond what the neighbors could offer. So again, by the time I got the call, He was actively dying, and we didn't have a plan for her, who had lived alone right up until that point. So manage your expectations. Yes, it's wonderful to have friends, and yes, it'd be great if they could bring supper by 1 or 2 nights a week. That's a wonderful thing. Or take you to the grocery store, or grab groceries for you while they're at the store. All of those things are wonderful. I would caution you about accepting assistance that feels, when you question it in your gut and you say, oh boy, I don't know. I don't know if this is really the right thing to do. And you know, most often you know. And if you don't, go to your provider. They should be able to give you guidance specific to mental health and mental decline, because that is a worry for all providers. They want everyone to be safe. So that kind of covers both that. And how can they be helpful and supportive without enabling, right? We all talk about enabling. So we want to promote well-being, but we don't want to enable them to stay in a place that feels like they're not really okay, even if that's what they want. Even if that's what they want. Reach out to Nest, have a conversation with them. Perhaps they can reach out to their family. I think there are avenues and ways to try to mitigate some of that. So further interventions, especially for aging in place, and I was really glad to hear Connie say aging in place for as long as possible. I think we all need to actualize that. In all circumstances, we can't stay at home. It's not always a feasible option. It can be cost prohibitive if somebody requires 24-hour care. That's somewhere in the neighborhood of $500 a day. That's a lot of money for private care staff to come in and stay with a loved one or stay with you. So I just want to say that yes, we're going to support that in all the ways that we can, but that sometimes it's not realistic. Home care is generally referred to as non-skilled services, and really that's more about reimbursement, which we won't spend a lot of time on, Medicare versus long-term care insurance, private pay, but companion care, housekeeping, meal prep, transportation, and some direct care. So it can be a home health aide, falls under that non-skilled service. For me, they are often the early intervention. And they may be the intervention that stays on board throughout the rest of your life or your loved one's life. Home health, and there is a difference, are skilled services. And they qualify for Medicare or private insurance reimbursement, but you have to have a qualifying diagnosis or event. So a provider has to write an order for home health, and they're specific. They'll say skilled nursing, PT, OT. So it can be for strengthening. You might have been sick and in the hospital for 2 weeks, and now that illness has improved, but you need some help. You need some PT and OT and get those legs back and strong. And so they might not order skilled nursing. They might just order PT or OT. They also provide social work services, which is also nice, especially after you've had an event. And now the advanced directive question has reared its ugly head again. A CNA can also come in through home health. So if there's skilled nursing services, then the skilled nurse can recommend CNA services, and that really depends on the frequency, on the availability, and the provider. They'll write those orders. But for me, these are generally early interventions. And so think about that. And you can meet with a home care representative or home health if it's ordered and talk about what it is that you need and want. What do you feel like? You very much need to be a part of that discussion. And they'll talk to you about minimums, shift minimums. Most of them have them. You know what I mean? It's hard to send caregivers out for an hour or two. So usually it's a 3 to 4 hour minimum, but that varies agency to agency. They'll let you know when you have a conversation with them. And what are you needing? You very much need to be a part of developing that service plan. And home health will be a little bit more defined right out of the gate, but the nurse will be integral into setting that up and what does your particular care plan look like, okay? So private pay for home care or long-term care insurance, and for home health, Medicare or private insurance with a qualifying event and a physician's order. So here we are back at advanced directives. We keep circling back around because I can't stress enough, and I'm going to keep saying it. I've so many times people have not had their wishes honored, and it's heartbreaking. So this is such an important piece. This is a free resource. It's a wonderful site. It is specific, you asked me, to North Carolina, but they have them. The U.S. government has them as well. Talks about all the different advanced directives, what they, are required. Some of them require a notary. Some of them require, most form and DNR require a physician's signature. Be mindful of the difference between a healthcare power of attorney and a durable power of attorney. So a durable power of attorney cannot make healthcare decisions for you. So durable is more about managing your finances and your estate. Healthcare speaks for itself. And you can designate more than one person for your healthcare power of attorney to serve at the same time. You can also list one, and then if that one's not available, 2, 3, and as many as you'd like to put on there. That is such an important piece. However, bear in mind, and it's more often that whoever you appoint as your healthcare power of attorney doesn't know, they don't have any say-so in your healthcare until you can't make your own decisions. I've taken more calls from daughters and sons who are their parents' healthcare power, and they're like, well, I don't think he's making a good decision, so I wanted to go this way. Well, I don't have any power over that. Unless he's incompetent, I can't. We have to honor his wishes because we all want our wishes honored, and that needs to be a conversation between you and your dad. But when and if the time comes that you're not able to make those decisions, be thoughtful and mindful about who you appoint, and make sure that they have a clear understanding of what your wishes are and that they'll grant them, because it doesn't always happen. So it needs to be a pretty hard and fast conversation. Like, this is not up for discussion. This is what I want, and if I can't make my own decision, I need to be able to trust you that you will make sure that that happens. So choose carefully. Living will, and those are honored. Those you can do online yourself. They do not have to be prepared by an attorney. They do have to be notarized, as does your healthcare power of attorney and your durable power of attorney. But I feel like they go hand in hand. I wouldn't do one and not have the other, the healthcare power of attorney and the living will. I think they should both be there. I think it's really important. You go down and you can't make your own decision, and nobody knows where your living will is, and now you have nobody to speak on your behalf. So I think those should be done together. So that's a wonderful website, very informative. All the forms are there. You can download them and take care of them. And then again, the most form allows you to pick and choose. DNR is a do not resuscitate. No, I don't want anybody jumping on my chest. No, thank you. I'm good. That's pretty straight, and it's called the goldenrod, just so that we all know that in North Carolina. I came from Massachusetts, and I'm like, what in the world is a goldenrod? And I found out it's a DNR, and it is gold in color, and it has to be the original. That's also really, really important for you to know. So EMS suggests that you hang it on your refrigerator, or you put it on the inside of your front door. Those are the two places that they will routinely look. If they come into a house where somebody's down and there's nobody to say, I can go grab the DNR, they will look routinely at those places. You can have it turned around so that the DNRs and like, glaring out for all your company to see. But please know that those are the only two places that they will look. So if you have a DNR and it's not in one of those places and there's nobody home to go and fish it out of the desk drawer, or it's under the desk, thing on the desk, then they're going to resuscitate you if you're not able to speak on your own behalf, because they are required by law to do that. So that's really, really important that you know, and it must be the original. It cannot be a photocopy. It has to be the original goldenrod. So now we're going to kind of go into, it has to be a brief overview, otherwise we'll all have dinner and I didn't order anything. So this is going to talk to you a little bit about senior care options. And senior care options that include aging in place, but also talk about assisted living, talk about skilled nursing facilities. Independent living is really just what you have in St. James, just in a smaller community setting, generally speaking. Sometimes you'll hear the term, there's a continuum of care on a campus, which just means that it begins at independent living and then it goes to assisted living and then to skilled nursing, and it's all kind of under the same umbrella, sometimes. So aging in place, and we all desire this. I don't know of anybody, honestly, who says, oh geez, I'd really love to go to assisted living as soon as I possibly can. Not one. And I've sat with a lot of folks. They might come to that later on, but they don't come to the conversation with that. I want to stay home. I want to stay home. I want to be in my home. I want to be with my loved ones. Thank you very much anyway. I want to look at my garden. So agency versus private duty, when you're looking at home care, not health care, home care, so those non-skilled services, there are many, many agencies that provide those services. There's also private duty. And there are ways that you can hire private duty and do it safely. And I'm not going to get into the specifics of that when we get to the end. I do have a sign-up sheet at the back if anybody is interested in further conversation with me. I am a senior care consultant. I'm happy to do that. But know that there are private care options. And the reason that that has become important, especially since COVID, is, as you all know, every healthcare setting is having staffing problems, without exception. So sometimes you'll go and you'll contract with an agency, and this is not all of them. I don't want to paint a picture that's a generalized picture, but I do want you to know that often they will contract with you for a particular service, and in the beginning it looks like they're going to be able to provide those services, and then they have staffing changes. They lose a few staff members, or they get more clients. And now they're divvying up, and so then you get a phone call, I'm sorry, I don't have anybody to send you today. Or over a 5-day period, you get 5 different caregivers. And so I want you to know that that happens. And I don't think it's malicious. I don't think anybody does it from a place of like, let's see, how we can tighten the screw. I really don't. I think that healthcare is, in my opinion, in trouble. I've been doing this a long, long time. So just know that you may find that that's a little bit cumbersome to land with an agency that can meet your needs. And again, I'm not intimating that they aren't out there, but they all share challenges. And I've consulted with them and collaborated with them, many of them in this geographic area, and they're very straightforward. It used to be that we didn't talk about it. I can remember in nursing people saying, don't ever say we're short-staffed. Don't do it. Now, they have signs on the door everywhere you go. We're short-staffed, thank you for your patience. Everywhere. So just know that there are some challenges for those agencies to meet the needs of all their clients. Sometimes. Adult day health. So there are places where adult day health is an option. So if you are the primary caregiver for someone who not necessarily even has dementia, but just needs some more stimulation, would really benefit for some social, and they're that personality that they would do well in that environment, you can contract with those adult day health agencies to have them go 2-3 times a week for 3-4 hours and get out of the house. And there's music, sometimes there's pet therapy. There's lots of good things that go on in those settings. So know that that's also an option and helps to keep you in home and aging in place. Family, we talked about this, friends, church members, volunteers, communities of support. Again, that is wonderful. And when I meet with folks, we talk a lot about tapping into all your resources, but manage your expectations around what they can provide. Okay? And then end of life care. That is almost always able to be managed in the home. Palliative, people are seen in their homes, can be seen in clinic settings and in facilities. But they certainly can come to the home, and then hospice as well. The only time that hospice patients are managed in this geographic region at the care center is for aggressive symptom management or respite. There's no residential beds in our geographic area for any of the hospices that serve this area. Long-term care. And understanding the challenges is a whole conversation in itself. I would say that it's similar to what we talked about with the agencies. Staffing is tough. I think for a very long time, the front care staff, who really are, they're your best or worst marketing tool in any situation. The caregivers were making non-livable wages or working multiple jobs in order to pay their bills. Experienced caregiver burnout much faster because they're balancing all these things in the air. I think we're working towards rectifying that situation. But I think it took COVID to cast some light on that to those folks, and specifically in Massachusetts, which is my second home, where they had multiple deaths in a long-term care facility because they were so understaffed. And so managing your infection control things and doing all of those is next to impossible. So I think we're working towards making that better, but we're certainly not there yet. So again, when I speak to folks and we talk about the potential for long-term care placement, you need to be involved. The days of, dropping mom off and I'll see you in a couple weeks, mom, are gone. If you want to be sure that mom or your loved one or you are getting the care that you need, there needs to be a lot more involvement, family involvement if possible. There are other ways that you can have assistance and just accountability. It's terrible to say, but there needs to be accountability. So in the skilled nursing facility, Medicare only covers short-term rehab. So there's 100 days over the course of a calendar year that with a qualifying diagnosis, Medicare will pay. And you can only use, you can use part of it and then save the remaining days if you have another event or another thing that goes on. But just know the only time they pay for your room and board is when you have a qualifying event and a qualifying diagnosis. Medicaid or private pay is also an option for long-term care. And as you can imagine, it's expensive. Medicaid beds they allot so many beds in each of the facilities. So sometimes there's a bit of a waiting list if you have Medicaid and you're waiting to get into a long-term care. There is also a spend down requirement to put in a Medicaid application. You have to reveal your estate, the value of your estate, and then you have to spend it down. And they monitor it pretty quickly. And their level of what you can be left with is pretty low. And it used to be that you could put money, send it to your kids, send it to, do you know what I mean? And 5 years. So if you can't make a transfer of your estate within 5 years when you're applying for Medicaid. So just know that those are all there and available. Assisted living is private pay, almost always except long-term care insurance. And again, some long-term care insurances, the older ones that were bought eons ago, have wonderful coverage. The ones now, not so much. So just if you're out and you're investigating those and you're talking to a broker, be sure you understand exactly what you're buying when you buy long-term care insurance. And memory care is in the assisted living setting is exactly the same. So it's private pay or long-term care. And if it's in the skilled nursing facility, then again, Medicare at that point probably wouldn't pay because there wouldn't be a qualifying diagnosis. Dementia is not qualifying for Medicare. So it would be a Medicaid application, would have to be fostered. So just again, this is a very broad overview. These are things that are out there. Short-term rehab happens a lot. You know, you go in, you have a hip replacement, you go over and you do rehab for a couple of weeks and then you come home. Yahoo! You know, and that's Medicare covered because that's a qualifying event. And when it's a PT or OT issue, you're strengthening, you're regaining your ability to do your activities of daily living, they have to be able to document goals so that you're meeting your goals. And so if you were to go in, and sometimes people don't fare well, even if it's just initially for short term, and they're doing or they're not participating really, but they're not making any gains, then Medicare will say, no more. And you still then have the option to do private pay, but there are very specific criteria for Medicare. How are we doing for time, Jerry? Is it 4? Okay. I'll try to breeze through so we can open it up for questions. Hospice and palliative care, understanding the level of service is so important. As a hospice nurse and a hospice referral specialist, that is the thing I think that people know least about. So I do want to spend a minute here. Palliative care is supportive care typically ordered to help and collaborate with community providers to manage either chronic illnesses or life-threatening illnesses. So they come in and they will collaborate on symptom management. If somebody's not comfortable, they're going to collaborate with that provider. Can we get them more comfortable? What can we be doing differently? And setting goals of care. So they meet with the patient. They meet with the patient and their family. And what is it that you want the end of life to look like? What goals do you have for your end of life? So it's really a pivotal thing. And for palliative care, it can be a one-time goals of visit. You don't have to have ongoing, but they can stay in and work to do that symptom management piece in education. There are no direct services other than the nurse practitioner who comes out. So there's no skilled nurse, there's no home health aide, there's no CNA with palliative care. It is offered in the home, in facilities, and in clinic settings. So the Zimmer Clinic, for example, at New Hanover, we have a nurse practitioner that sees patients there, that helps with pain management and goals of care. Social work services are generally available in palliative care, and just generally it's short term. And each individual agency kind of dictates what that looks like. And that's based on number of people they're serving and number of providers they have. And of course, they then will bridge to hospice when that becomes important. So hospice services are comfort care only. So you can't be seeking any aggressive treatment for a life-threatening illness, and you must have a prognosis of 6 months or less. Doesn't mean everybody, we get out our little, we're looking at our little magic ball and see, but it is an educated guess, and it is made by a provider, and they have to certify that if your disease process continues as anticipated, that you have a prognosis of 6 months or less. Palliative care, one slide back, doesn't always have that requirement. Lower Cape Fear has an 18-month prognosis. Just because they are serving so many people that they had to find ways to serve the ones who were more in need in the moment. When you get hospice services at home, you get a skilled nurse, comes once a week, and then more frequently when you need her more. You get a home health aide, sometimes 5 days a week. More often, 1 to 3 times a week for an hour to help with activities of daily living. You get a social worker who's assigned to the team, so you actually have the team. You have, of course, that nurse, and you always have access to a provider through your nurse, 24 hours a day. So if you're taking care of somebody at home and they're in trouble, they've changed, they're not comfortable, you pick up that and call that 800 number, and they're going to either reach your case manager if it's during the day, or they're going to call the on-call nurse. And then the on-call nurse is going to come out and assess, and then she's going to call the provider. Durable medical equipment, hospital beds, bedside commodes, alternating pressure pads for folks who are thin and have a risk of ulcers, shower chairs, urinals, all that durable medical equipment is covered. Oxygen, supplemental oxygen, and your meds. And if any of your meds aren't covered under the formulary, you'll know that at the time of admission. And volunteers. We have wonderful volunteers. Most all the hospice organizations do. Hospice facilities, general inpatient or GIP, you'll hear that if you have anybody on hospice and they say, oh, I'd like my mother to go to the care center. We have very specific criteria. It's driven by Medicare, but it's also driven by the number of beds that we have and how many patients we serve. So it means that the patient is requiring aggressive symptom management. Typically what that means is that the nurse has been out in the home, on-call has been out there several times in the last few days. We've made several dosage adjustments, and this person's still not comfortable. And the nurse is going to call the on-call provider, and she's going to present this patient, and he's going to say, transfer him to a care center. Because that's what they do. We get them in 24 hours, you've got a nurse, you've got providers that are there. But again, there's very specific criteria for that. Residential care, we don't have any in this geographic area. There are hospices up in Carteret County. There's a couple that are up that way that do offer residential beds. So it's for patients who don't require necessarily aggressive symptom management. They might not have a safe home situation. They can't get into a nursing home, but they need somewhere safe to be. So they do offer those residential beds. Again, we do not have that in this area. And then respite stays. We do offer see if I can get my frequency. I think it's every 2 months. The case manager can request a respite stay for the patient so that her primary caregivers or the care team gets a break. And that's generally 4 to 5 days. And they go to one of our care centers. We can contract with facilities, long-term care facilities. We do have some that we contract with, so that we can provide that respite stay. It's so important when you're the primary caregiver to be able to catch your breath. And I think we're at questions. So I know, is it Meg? Yay, there she is. She's got the microphone so that I can hear you. So if you have a question, why don't you raise your hand, and then Meg can make her way over there, and we'll see if we can answer them. Medical orders for scope of treatment. Woohoo! There we go. Medical orders for scope of treatment. So that's a pretty good description, because that's exactly what it is. And it's going to ask you just about everything. Do you want to be transfused with blood? Do you want to be intubated? Do you want to be intubated short term if the prognosis is good? Do you want artificial feeding, a peg tube? Or, I mean, it's really pretty detailed. And it's wonderful that we didn't used to have that. Like, it was kind of, you're all in or you're all out. You know what I mean? And Living Wills used to address that. But again, that was one of those things that kind of fell through the cracks, unfortunately. So it is a wonderful form. And all of your providers will have it in their office. So if you just ask, and you don't have to fill it out while you're there, you can just take it home and look at it. But that site that I gave you back earlier will also have it. So I would say, in my experience, as far as, and are you asking like about hospice services and the ones that, so Brunswick County, Columbus County, Onslow County, Duplin County, New Hanover County, Pender, and parts of South Carolina, because we have Mercy Care, which is part of Lower Cape Fear Life Care, and they service Conway and kind of that area of South Carolina. But further out in South Carolina, there are residential beds that at some of their care facilities. But yeah, it's a pretty big area, you know, to get that. You could certainly opt to go outside of the area, you know, to find one. Carteret County, further into South Carolina. What my experience is it becomes a hardship for the families who want to come and spend time. Not typically. And so what would happen was, because they would stay aware, they know when you move into a long-term care facility, you have to divulge your financial kind of situation. So they have a pretty good idea of when you're spending down and you're getting close. So then the social worker will come and say, you know, it's probably time for us to make out a Medicaid application. And at that point, you have spent down so that your Medicaid application should be approved. And then you would just stay there. And you would be in a Medicaid bed, but it doesn't mean that you'd be in a different bed. They allot so many for each facility. And so you would just take one of the Medicaid slots, for lack of a better term. But no, we won't boot you out and put you in another bed. You're welcome. So that's why I say be really, really careful when you're sitting with an agent and talking about purchasing long-term care. Make sure you understand what you're actually getting for that, because there's lots of exclusions, there's maximums. You know, this is the max amount we'll pay a day. So when I talk to you about $500 a day, and that's accurate. The going rate for a private caregiver, because you're going to pay a little bit higher if you go through an agency, but if you hire a caregiver from, well, we won't go into the sources, but if you find one and you're paying between $18 and $22 an hour, that's the going rate in this geographic area. That's just about $500 a day. So often your maximum's $260. So once you've tapped out, and then there's a process, and they have to submit. I mean, there's lots to talk about with that, but there are lots of people out there. And for anyone, if I can help you, if you're in a situation and you're not quite sure, you know, long-term care, how do I get that? How do I, you know, apply? My husband really needs it, or my wife really needs it. Please don't hesitate to reach out. You can reach me through this email address.
I just wanted to make a comment. I've been a nurse for 40 years, and I've helped a lot of residents around St. James.
Yes.
And a couple of years ago, I helped someone who the wife was very ill for a long period of time.
Yep.
She had a DNR. Everyone was there,
yep.
the EMS and all. But we couldn't find the DNR, which is good that you posted. But he had taken it to the hospital when she was in at one point and then never brought it out.
Yes.
So they had to continue to keep her alive.
Yep.
And the other thing I pass on now, which sounds sort of remote, but as we're getting older, our organs really aren't that valuable. And if you have that on your license, they'll keep you alive to retrieve your organs. So I think it's important for us, if you don't want to be sustained. As she went out the front door, I told myself I'm going to let everybody know this, because it was during COVID and it was a really treacherous situation. So if you
It
don't
is.
want to be sustained, take that off of your driver's license.
Thank you for that, absolutely.
And if you do have a DNR, does it last your whole lifetime?
It does, until you revoke it.
But if you revoke it or hide it in the drawer or whatever, then you can pull it out later, right?
You sure can.
Yeah.
Absolutely. Just have to know where it is.
To everybody to know.
Yes, it's very important, and I have more than once, somebody has been resuscitated and been devastated. They were not happy.
Okay, there's a follow-up to that last comment.
Okay.
I just wanted to make a comment about an experience I had where even though the husband was home and the wife had a DNR or wanted not to be resuscitated, they didn't have the form
That's right.
and the EMTs wouldn't take the husband's word for it. So
Right. Oh, no. And please understand that they legally can't. It's not even that they won't, it's that they can't. And it can't be a copy. So if you said, oh, well, you know what, I made 5 copies, I've got one in every room, and here you go. If it's not the original, they're not going to honor it. They can't, legally.
Good afternoon.
Hi.
One of the things I think we need to emphasize too on the living will and the so forth, you need to update those at least once a year.
Mm-hmm.
A lot of folks do not realize that,
Yes.
and it becomes a factor in the last moment.
Yes, absolutely. And I would encourage you to look at that website because it is really detailed. I do know that the most form requires a signature every year, just so that you know. So, and you know what, that's a really good thing because what I thought I wanted 5 years ago may not be what I want today. So, but the provider won't remember that. That's going to be your responsibility to keep track. If you have a MOST form, when was the last signature? And when you see the provider and it's been 12 months, get a new one. And talk about it if you need to make some changes.